about developmental milestones. So please, could you include that in your registry? We want to know how our babies are doing. And so we added that in the registry. And today, a few years later, Ahlam is going to be presenting developmental milestones in young children, 0 to 5, 104 children actually across those different sites. So I'm really thankful for that and for all our participants and Shriners teams that made this project possible. And the next speaker is Caroline Elfassy, who has obtained her PhD after 5 years of work with,
Thank you.
with twin boys. So Ahlam, next year when you come back,
yes,
you
have the twin boys. Or the twin boys.
Maybe both.
Who knows?
And so Caroline's project is to develop a measure to look at the upper extremity in children with arthrogryposis. And we have several members in this room who really helped us develop this measure. Lisa Wagner, who's here from Shriners Greenville, and her team in the back. We're very thankful for all your help and expertise with Dr. Heyer and the rest of the team. So that wouldn't be possible without the funding from Shriners, but also the great team in behind Caroline's work. So I'm done with my part now. So Ahlam will start. Is that a good time, Jean? Perfect. Thank you again for your attention.
Thank you. I think, yeah. It's on. Perfect. So hello everyone. Thank you, Dr. Noémi, for the introduction. So as Dr. Noémi said, I'm Ahlam Zidan, and I am a PhD student at McGill University doing my work with Dr. Noémi. And my PhD is mainly about the developmental stats and the mobility function of children, young adult, and adolescents and young adult with living with arthrogryposis. But today I will be just sharing with you part of my PhD, which is relevant to the developmental milestones, the achievement of developmental milestones of children who aged between 0 to 5 and living with arthrogryposis. And also some contextual factors that we believe are going to be associated and correlated with the developmental or achieving developmental milestones among this population. Okay. Let's see what's not working. Perfect. So as we know, the development of a child is an ongoing process marked by consistent emotional and physical growth. Most children follows a similar sequence in reaching developmental milestones. However, some children might show signs of developmental delays, which refers to a delay in achieving developmental milestones or key developmental milestones like standing, sitting, or walking. Research reported delays in reaching both, specifically both like motor and communicative milestones among children with disabilities in general. And usually parents are the first people who notice this kind of delay that in their children in walking or standing or sitting, for example. Also, studies found that there are many contextual factors that could be related to the medical condition itself or the child or even the parents that could be associated to some extent to the achieving specific key developmental milestones. And this association or correlation with the level or the achievement of developmental milestones have been well studied in other populations, for example, cerebral palsy, but it's not the case when it comes to AMC population. So it has not yet been studied how these contextual factors are related to children, the children with AMC, living with AMC, and their achievement of key developmental milestones and the developmental trajectory in general. So the objective of my study, first of all, I wanted to describe the developmental status of 104 children living with AMC. And the second objective is to try to understand how these contextual factors that I already just mentioned in the previous slide, that could be related to a delay in achieving specific milestones, or of course, and for children aged between 0 and 5 years. Why we need to understand this and why we need to answer these questions. So answering these questions will help, first of all, families to make informed decisions about how to, what part of the healthcare system or services that they need to navigate, they need to ask for. Also, to help them understand how these contextual factors could be related to the delay that they notice in their children standing or sitting or any other key milestones. Also for clinician, it assists clinicians when they're creating that plan, therapeutic plan for these children to be tailored to their needs. So, which also will help a lot with progressing with the therapy and seeing positive results. Finally, for researchers, answering these questions is important because it helps to, we're hoping that answering these questions will help researchers to create or inform their hypothesis and rationale of studying and digging deep when they're trying to understand specific factors that might be really or strongly correlated with delay in developmental milestones. And maybe they find a way that maybe these factors can also predict future limitations or future developmental status for these children. So my study, or this study, will be involving 104 children between the age of 0 and 5. And these children were recruited from 7 Shriner hospitals around Canada and the US. And we assessed or evaluate the developmental status of these children using a questionnaire called Ages and Stages questionnaire. This questionnaire helped to evaluate 5 important domains, which is communication, gross motor, fine motor, problem solving, and personal social skills. And of course, we conducted some statistical procedures to help us to see this, if there's any patterns and association between the factors and the developmental status of these children. So I will be now presenting the results of just the first project with describing these, the statistical or the developmental status of these 104 children. So starting with the children characteristics, we found that the age range of these children ranged from 2 months to 5 years. And as you can see, that 3 years group and 5 years group has the highest number of children. Also, for the biological sex, were almost even between males and females. For the birth weight, the mean weight was 2 kilos, 0.80 for 93, because we had only information on 93 children. So the mean age the mean weight were 2 kilos, 0.80, and for the gestational age was the mean also 37.6 weeks. We were also interested to know if these children had spinal anomaly at deformity at birth. So we asked these questions, and only 21% of the children reported that they had it was reported that they had spinal anomaly at birth. Finally, we wanted to know, because other studies in other populations, we found that how many days they stayed in the NICU or the child readmitted was very correlated with the developmental milestones of the children. So we were interested to know this population that we had of children with AMC, how many days they stayed in the NICU. So only 55 children, they said yes, they stayed in the NICU, and the mean number of days were 35 days, 0.58. So now this diagram is presenting the reasons, or the most common reasons these children, they stayed in the NICU or readmitted or hospitalized. So we can see that the most common reason was feeding difficulties, with 24.8% of the children, they reported that was the main reason that they readmitted or stayed in the NICU. And the second and the third reason is the breathing problems and diagnostic for diagnostic investigations reason. Jaundice was only 6% of the children, they were readmitted because of jaundice. So the remaining 41% of the children, they reported other reasons that related, some of them to the cardiorespiratory system, but there were like each reason was reported once or twice, so it's not really very common, but the most common one was the feeding difficulty. As we all know that one of the most common characteristics of arthrogryposis is contractures. So we needed to know this sample, or this population, how is like the location of the contractures. It's very important factor, we believe, in their developmental status. So we found that only 4 of the 91 children, they had only upper limb contractures, 7 they had only lower limb, and the remaining 80 they had both upper and lower limb contractures. So for the location, the most common location that was reported to have contractures was the foot, the hand, the knee, the hip, and the shoulder and the elbow. The remaining, which is the jaw, spine, neck, and the toes, were less reported, but still the percentage was kind of high. Now we wanted to know also the surgical intervention. So we noticed that almost all the children, they had at least 1 to 2 surgeries. And we wanted to know where is the location of these surgeries. And we noticed that there is a pattern between the location of the surgeries and also the location of the contractures. So the same thing, the footwear was the highest number of surgeries that had been done in the foot, then the knee, and also the hip, shoulder, the knee, and the spine, and the elbow, actually. The remaining, the toes, the fingers, wrist, and the thumb were the least joints that were reported to have surgical interventions. So now we finish from the child characteristics, or the factors that related to the child, and the factors that related also the condition, the AMC, arthrogryposis. And starting with the parents of these children. So for the age of these parents were almost like around 30s, the beginning of 30s. And for the education, the highest number of parents, they had a bachelor, college, or undergrad degree. And for the employment, 67% of the parents, they reported that they are employed. For the marital status, 72 were either married or in common law relationship, and the remaining were either like single or divorced. So for the parental stress, we can see here that the highest number of parents, they reported that they had sometimes stress, and this stress, we were really wanted to know the stress that's related to taking care of a child with arthrogryposis, navigating the healthcare system, and all of that stress and challenges comes with it. So 43 parents that they reported that sometimes, and then it comes in the second is the frequently. Like 33 parents, they reported that they had frequently or nearly always stress because of that. And only 26 reported that never or rarely. We also wanted to know some information about the child before a birth, or when the child was in the uterus. So we asked about, could you feel the baby move? And 84% of parents, they said yes. Also, if there was any unusual fetal movements. Only 22 reported that they noticed that unusual fetal movements. And did fetal movement decrease as pregnancy progressed? Only 27 noticed that there was some decrease in the fetal movements during the progression of the pregnancy. And the type of delivery, 72% of the deliveries were cesarean. The rest, 72 were cesarean. So this was the highest percentage. And the last question we asked is, was AMC detected in the utero? And was kind of half-half. So only half of 52% of the parents reported that the child was diagnosed with AMC in the uterus. So now, as I mentioned earlier, we did evaluation of the developmental stats of the children using the ages and stages questionnaire. And this diagram can show that the 5 domains, the main domains of these children, how they presented their developmental stats. I will go through each domain by itself. So starting with communication, you can see here that almost 59% of the children, they had good communication and comparable to their peers without disabilities. And only 21 reported delay in their communication skills. Moving to gross motor, here we can see like how almost 85% of these children, the 104 children, almost 85% they reported delay in their gross motor function. For the fine motor skills, it was almost even between those who reported delay in their fine motor skills and those who had good fine motor skills and comparable to their peers. Moving to problem solving, we can see that almost 62% of the children had good problem solving skills and only 27 who reported to have delays. Finally, the personal social skills, and we can see that almost half of the population, like 46%, they reported delay in their personal social skills, and 32% were they had good personal social skills. And I just wanted to mention that the yellow, it is the 21%, it is those children who are close to the cutoff, which means that they still reported to be delay, but the delay is like kind of close to be comparable to their peers. So, but still like under, but still like kind of close. So again, here, all of the domains, as you can see, we noticed that like most of the children, the communication skills and problem solving skills were there's no delay in these. There's not a huge delay in these domains, but only the gross motor function and personal social skills that showed delay. And we are so interested to continue with the next stage, which is trying to understand how these factors that I already mentioned that related to the child, the parents, or even the condition itself related or could be could contribute to the results that we saw on the developmental milestones, the communication, the gross motor, and etc. of domains. And also, one part of my PhD that I'm interested to and really excited to go further and started very soon, is to try to study and understand how these factors and other also related factors could contribute to the mobility function of children and adolescents and young adults aged between 5 and 21. So yeah, I'm so excited for that. And thank you so much. And if you have any questions, I'm so happy to answer them.
Any questions? Comments, thoughts? Have you completed your PhD.
Oh, I wish. Let's hope next year. When I come here, I will tell you. I will share the news.
I know this answer may be obvious for some, but you might come back and different defining gross motor skills.
Sure. So, yeah. So, gross motor skills usually is that motor functions where children, for example, standing, walking, where when it comes to fine motor skills, it's more that's relevant to the movements that's related to the hand, where it's like delicate, more functions, motor functions that more delicate, where the children use small joints more than using big joints. So this is how we differentiate between motor function or gross motor and fine motor skills. Thank you. Should I?
You're unplugged. That's not me. I sent, well, Ted has it. So. All right. We'll find it. That's me, though. Oh, yep.
That's where you are.
That's where I am. We'll fix that. Oh, well. Thank you. Okay. All righty. Great. Can you hear me? This works? Okay. This is fun navigating this. But anyway, so my name's Carolyn, and I actually did complete my PhD this past January. So I'm actually very excited to share all of the information that we were able to find within the Shape Up, because I came in 2017 to my first AMCSI conference with an idea and hope in, wanting to develop something like this. So seeing the different phases and seeing how this project has grown over the years has been so fun, especially for one particular phase, which was the focus group on caregivers and parents of kids with AMC, and how we can incorporate what your guys is, what you identify as needs and what you think is important to include in such a measure. So now I'm really excited to share, the final tool and the final measure with you guys. And if you have any questions, we'll answer all of those. So the impact of upper extremity function in AMC, as we know, approximately half of patients with AMC have upper extremity and lower extremity involvement, while 17% have upper alone. Upper extremity function plays a crucial role in the overall quality of life and autonomy of individuals with AMC. So we know that it involved in dressing, in toileting, grasping, fine motor, fine motor use, feeding. And here we could see a baby with the more typical classic position at birth, with the shoulders kind of internally rotated, the elbow extension, wrist flexion, thumb and palm deformity, etc. Oh, bring my closer. I should have used the thing. Okay. So in terms of rehabilitation and AMC, and maybe just a bit of a background information for how this came about, is that I was a new grad starting an AMC-specific clinic at the Shriners, and being, evidence-based and having just recently graduated, I wanted to use a standardized outcome measure for this population, and nothing was available, and we couldn't compare to standardized norms. So when looking in terms of rehabilitation, we saw that there was a huge gap, and it was really something that we wanted to address. So the first thing we did was look at a retrospective review with the aim to describe the orthopedic interventions and functional outcomes of a large cohort with AMC. This one was specifically followed at the Shriners in Canada. And we saw that in that review that participants had on average 4.35 operative procedures, and proximal upper extremity involvement played a critical factor in reaching independence and self-care. So we knew that they were undergoing surgical interventions, but we didn't know how that was being measured and assessed. Obviously, in terms of rehab, the goals and objectives to treatment differ and evolve based on the developmental stages. So as Ahlam just said, the infant goals versus the toddler versus the school age are all different and trying to reach that autonomy and skills. So what we kind of were performing and were doing as rehabilitation and occupational therapists was, stretching and splinting over the first year of life and seeing where that need was and what that goal was and how we could bridge that gap for the child, but we didn't have anything standardized that we could use. So the question came, what outcome measures are currently being used in rehabilitation for children with AMC? And as we could see from this list, it's very much questionnaires based. So the PODC, the PedsQL, the PROMIS. We also had a little bit more of our objective or observer based outcome measures, which are, the basic standardized range of motion or strength assessment, but that was kind of it. So we didn't know how the child was performing a specific task. We didn't know which joint or muscle was the one that was limiting the function, and we were unable to compare to any norm. So after a lot of phases, a lot of back and forth, a few years, we came up with the Shriners Hospital Arthrogryposis Pediatric Evaluation Upper Extremity, or SHAPE-UP for short. So I wish I had a pointer, but you could see on the left-hand side over there, it's basically a kit comprising different tools. So we have a vest, shorts, different balls, scissoring, markers, etc. And originally, when we had developed it, it contained 11 tasks, so performance-based tasks where we ask the child to perform a specific task. So, for example, pick up a Cheerio, bring it to your mouth, place it back down in front of you, and let it go. And that specific task was focused on looking at the joint of the thumb, finger, and elbow. So we kind of went about that for the 11 tasks that we developed based off of like I mentioned, focus group information from caregivers, from different clinicians, from the literature. And we developed also a 5-point task completion scale. So ranging from the child is unable to attempt to complete all the way to the child scores a 4 when they can actively perform it independently. And I have little videos here. There we go, if they work, hopefully. Yeah. Yes, something's happening. Okay. So we could see for this specific task, which was pick up a Cheerio, bring it to your mouth, place it back down in front of you, and let it go. The child or teenager, the teenager in red, has distal type amyoplasia, distal type arthrogryposis, and she is not exhibiting any really limitation in order to grasp that little Cheerio, bring it to her mouth, and put it down. So she was scoring a 4 overall in all of the subtasks. Whereas the young boy in blue over here, he's kind of compensating because he's, getting that passive range of motion from the table. He's hyperflexing his body to just get that extra range of motion. So in terms of the task completion, he was able to do it, but he wasn't doing it as easily, we'll say, as the other person. But what was unique also of the SHAPE-UP is that in addition to giving us a score for their ability to perform, we were also getting information, more descriptive information as to how that joint was positioned while they were performing the measure. So we could see here that although, they were scoring a 3 and a 4 differently for the bring to mouth, the position was the same. So that gave us a bit of information that we wouldn't have had otherwise. Another example here for the ball throwing activity. So same thing, where one was getting a 4, the other one was getting a 3, and that information or that extra layer of, performance really came from the joint analysis that's very unique to the SHAPE-UP. So in terms of, methodology and stats and all the fun stuff from my perspective, the purpose of this particular phase was to evaluate the psychometric properties of the SHAPE-UP task completion scale using a rash analysis, which is more of a, what's the word I'm looking for? Not classic. Modern, thank you. Modern type of analysis. as well as determining the strength of correlation between the number of joints that are involved if you have, let's say, a shoulder, an elbow, and a wrist versus less joints involved, and the task completion scale. So how we achieved this was through a cross-sectional study with data collected at 6 different sites. And in order to power this type of analysis, we needed to have approximately 100 participants, which we did achieve. We did it. So in terms of the results of the demographic information here, I'm just going to quickly go over it, but we could see that we broke it down into age groups. So 1 to 2, 3 to 5, 6 to 10, and 11 plus. And this was just based off of developmental milestones of, hand development as you get older. And we can see that, the group of 1 to 2 year olds was, the smallest one at 7 participants. So we're kind of taking that a bit with a grain of salt in terms of the analysis results for that specific group. But other than that, in terms of the baseline data, once we ran it into this software program, we saw that we had the scoring categories were not really working within this specific model or analysis. So what we ended up doing was we rescored the data basically on 3 categories. So instead of 5, it's now 3, and we've narrowed it down instead of 11 tasks to now 7 tasks. So we broke it down. It's even faster and better to administer now. And we were very excited because it fit the model, which meant that we had proper content validity, construct validity, and a good reliability. So based off of all of these fun graphs, you'll just take my word for it. So now they look good. And in terms of the second aim, which was the score correlation between the joints, the number of joints involved in the task completion scale, because we had a lot of missing data, unfortunately, we were not able to find any significant difference. However, there was a slight negative correlation, which did indicate that the more joints are involved, the worse the overall score would be. But as I mentioned, we didn't have enough data to really power that. Oops. So this is just an example to show you how, although those kids kind of still had a different score, from a 4 to a 3, that difference still came up now that we collapsed the categories from 5 to 3 points. So we would still see that difference of ability to perform a specific task for the children. So in terms of future work, although I said that the modern psychometric properties did fit the model, we still want to look at the more classic type of properties. So we have inter and intra rater reliability, as well as retest reliability that we're going to be looking into, and the responsiveness as well. So we want to know, as a baseline data, if you're going to have a surgery, how is that tool going to pick up on the differences in your ability to perform a task after a surgery, for example, as well as looking at the validity with different questionnaires, because there are no other outcome measures that are performance-based for this population. So yeah, obviously a huge shout out to the whole team, research lab. This project would absolutely have not been possible without each and every one of your guys' help. So thank you very much.